Welcome, everyone. I'm Kevin Volpp, a professor at the Perelman School of Medicine and the Wharton School, and the founding director of the Penn Center for Health Incentives and Behavioral Economics. We are delighted to welcome you back to this special keynote event co-sponsored with the Behavior Change for Good initiative. I'm joined today by my colleague and co-host, Katy Milkman. Katy is a professor at Wharton and the co-director of the Behavior Change for Good initiative, who will have the pleasure of introducing our fabulous keynote speaker.
Thank you, Kevin. I am very excited to have this honor because Amy Finkelstein, who's giving our keynote today, is one of the people I most admire. So really, really excited that she's here with us. I'm going to read her bio and then we will pass the baton to Amy to dazzle you with data and insights. Amy is the John and Jenny S. McDonald Professor of Economics at MIT. She is one of the most influential voices in health economics and public finance. She is the co-founder and co-scientific director of JPAL North America, where she helps lead rigorous research on critical policy questions. And she also serves as co-director of the Economics of Health program at the National Bureau of Economic Research. Her groundbreaking work on insurance markets and healthcare delivery has earned her so many honors, it's actually a little bit overwhelming, including the MacArthur Fellowship, the John Bates Clark Medal, and the Ash Econ Medal. And that's just a short summary of the big ones. Beyond her research, Professor Finkelstein is deeply committed to mentorship and advancing the next generation of economists. And we're just absolutely thrilled to have her keynoting for us today. She's going to be sharing her insights and latest work, talking about facts and fallacies, rethinking U.S. healthcare. So please join me in offering a very warm welcome to Professor Amy Finkelstein, and I will pass the baton to her in just a moment before giving you two key instructions that I have to remember to say. One is to please put your questions for Professor Finkelstein in the Q&A box, and Kevin and I are going to be supervising and sort of monitoring, and then we will come in for a Q&A after about 40 minutes, and upvoting is enabled. So if you love a question, please upvote it. And now I will pass the baton to Amy. Thank you so much for being with us, Amy. We're so excited.
Thank you so much to Kevin and Katy for inviting me. And I guess thank you, Katy, for that overly generous introduction. I say I guess because I feel all I can do now is disappoint everyone, but I will do my best not to. Can everyone see my screen now?
It's perfect.
Awesome. Okay, so as Katy said, I'm going to be talking today about facts and fallacies in rethinking U.S. healthcare. And so by way of background, I want to start with, a few widely touted facts about U.S. healthcare that if you spend time working on U.S. health policy or reading about it, or even sometimes are just a casual, consumer of the media, you've probably seen many, if not all of these facts. The first is that a quarter of healthcare spending on the elderly occurs in the last year of their life. A second is that the top 1% of patients account for almost a quarter of healthcare spending. And a third widely touted fact is that some regions of the United States have much higher healthcare spending than others. I've highlighted Miami as a high spending region and Minneapolis as a low spending region, but the higher spending regions don't tend to have better health outcomes. I also wanted to just flag two widely touted facts about health insurance in the United States. One is that the emergency rooms are the main source of healthcare for the uninsured. And the last is that over half of bankruptcies involve people with very large medical bills. So hopefully many of you have heard of some or not of all of these facts talked about. And somewhat to my surprise, because often you hear a lot of stuff that isn't true, these facts are all true. Then often you hear about these because they suggest easy fixes. So if you're concerned that the US has, really high healthcare spending, almost 20% of GDP, much higher than other high income countries that are more about 10 to 12% of GDP, a lot of that publicly financed, worry no more. High healthcare spending is no problem. There's a lot of waste that can be cut. All these people who are near the end of life that we're spending money on, this concentration of spending on super utilizers, the high spending in Miami compared to Minneapolis. We're here to help. You're concerned maybe that the United States is the only high income country without universal coverage. Also, no problem, easy fix. We can expand health insurance and save money at the same time by getting the uninsured individuals out of the high cost and not pleasant emergency room and into cheap, effective primary care. And what my talk today is about is that unfortunately, although the widely touted facts about US healthcare are all true, the inferences, those common inferences that tend to be drawn from them are all fallacies. So that is, what the talk is going to be about. And hopefully in doing so, I'm going to highlight, the types of logical fallacies that I think come up much more widely than just the few examples that I'm going to be presenting today, which are, drawn totally self-servingly from my own recent research. So they're not a representative sample. Okay, so I wanted to start with healthcare spending at the end of life. And that first fact I mentioned, that healthcare spending among the elderly is concentrated in the last year of life. I had heard this fact a lot, and as I said, I was somewhat surprised that we were able to replicate it spot on in the data. So, the elderly, about 5% of them die each year. But if you look at healthcare spending, a quarter of all healthcare spending is spent on people who then die that year. So as I said, that fact is true. The conclusion that's drawn from it is the spending is wasted. It could be cut without harming patients. This is an article in an op-ed in the Times, or a column in the Times, that asks, why are we spending all this money on people who are on death's door, just throwing good money after bad? Are there limits to what Medicare should spend on a therapy prolonging someone's life by a month or two? And the fallacy that it turns out that this line of thinking represents is something known as hindsight bias, that those who end up dying are not the same as those who were sure to die. And the way we figured this out is we analyze spending from an ex-ante perspective. This was joint work with several co-authors, Laurent Einev, Sendel Mullnathan, and Ziad Obermeyer, where we had very, very rich data on patients and their health and their medical spending. And we used, sort of at the state-of-the-art machine learning to predict at the time that they're getting their care, what is their probability of death within the next year. And somewhat to at least my, and I think all of our surprise, we found that they say nothing in life is certain but death and taxes. That may be true, but the timing of death is highly unpredictable. So if we took these are all elderly patients, and we look at the share of spending on individuals who had predicted mortality above 50%, and I think that's a pretty low bar. When I think that when we think about people spending money on people who are about to die, we're thinking of probabilities, mortality probabilities for the year that are considerably north of 90%. We found that even if you just look at people with a predicted mortality above 50%, only 5% of spending is on those people. We then tried to narrow in on sort of what we thought of, we could find in the data that looked like the sort of analog of what people have in their mind of people who are near death's door, who are, having a lot of spending on them. So we looked at the elderly who enter the hospital with metastatic cancer and have predicted annual mortality above 90%. That's only 1% of people. So another way of saying it is you can find people who have very, very high spending and are about to die. These anecdotes are not made up, but they're very, very rare. And so what's going on is, spending is not randomly assigned. We spend healthcare, we use healthcare resources for people who are very sick, and some of them end up dying. So ex post, they are dead, but that doesn't mean that ex ante, at the time we were spending the money on them, we knew that they were going to die. So that doesn't mean that they were ex ante hopeless. Maybe an analogy just from regular life, if you've ever been lost your keys and you're searching all over for them, and you look everywhere, you look in the kitchen, you look in the bedroom, you look in the car, and finally somewhere you find them. You've probably heard someone say, or you may yourself have thought, oh, it's always the last place you look. Well, but that's hindsight bias, right? That's because once you find them, you stop looking. It's not because literally it's always, that was that place that it was going to be. So I think that's a very important, caveat to this notion that we can obviously just cut healthcare spending on people who are about to die, because we don't actually know that they're about to die at the time that we're spending the money. All right. A second and related fact that I wanted to talk about is the concentration of healthcare spending on what are known as super utilizers of the medical system. So healthcare spending in the United States is heavily, heavily concentrated. If you look at, the bottom 50% of patients in terms of the amount of healthcare spending in a year, we're only about 3% of medical spending is on those bottom 50%. That makes sense, right? They're healthy, they're maybe doing some routine preventive care, but we're not having much spending. If you look at the top 10% of healthcare spenders, patients in the top 10%, we're spending 2/3 of medical spending are concentrated on 10% of the population. The top 5% of patients in terms of spending account for 50% of annual spending, and the top 1%, the so-called super utilizers of the medical system, account for almost 25% of annual spending. In other words, 1 in 100 patients are accounting for $1 in $4 being spent. And so not surprisingly, this has prompted a lot of interest and design of care management interventions that target these very, very high cost patients, these top 1% of healthcare spenders, the so-called super utilizers, to try to see if by better case management and wraparound care, we can reduce these really, really large amounts of spending and presumably not only improve things for the patient, but dramatically reduce healthcare spending in the United States. And many of these programs, in fact, when you look at them and you look at what happens after the case management interventions occur, you see you go into these super utilizers and you provide wraparound services or post-discharge coordination of care, they show very large subsequent declines in healthcare utilization. And so that's led to the conclusion that these interventions, are helping to reduce healthcare costs and improve health outcomes. These are some examples of, positive press that, these programs have gotten. This frequent flyer program, as in very frequent visitors to the hospital or emergency room, that's really reducing or grounding hospital soaring costs. The idea that we can lower medical costs by giving the neediest patients best care. One estimate of a groundbreaking program in Camden, New Jersey, which is the one we ended up studying by the Camden Coalition, was that if you looked at patients, their hospital bills were averaging 1.2 million per month before the Camden Coalition got involved, and just over 500,000 afterwards, a 56% reduction. Unfortunately, this type of analysis falls victim to another common logical fallacy, which is that of mean reversion, that if you select when things are very, very different from the mean, in this case, very, very high spending, even if you don't do anything, naturally, the level of spending is going to revert to the mean. And the way we realized this is we worked with the Camden Coalition. Dr. Jeff Brenner was running it at the time in Camden, New Jersey. And to their considerable credit, despite the fact that they were getting enormous amounts of positive press, like that Atul Gawande article and others, and money to scale up their intervention program, which is focused in Camden, New Jersey, an extremely economically depressed part of the country, and they're working with some of the sickest, most vulnerable patients in that community. These are people who've had 2 or more hospital admissions over the last 6 months, are suffering from a variety of chronic conditions, and they're doing this wraparound post-discharge service to try to prevent them from cycling back into the hospital. To their considerable credit, they partnered with us to do a randomized control trial of about 800 patients and what happened when we randomized them to either getting the Camden Coalition's wraparound service or ordinary standard of care. This was ethical to do because despite the considerable success that the Camden Coalition was having with fundraising, needless to say, they were not able to reach all of the eligible patients they were targeting. And so rather than just, they were reaching about half of them, and rather than just have them ad hocly reach half of them, we made sure they systematically randomized and reached only half of them. And so we can look at what happened. So in the treatment group that actually was randomized into getting these wraparound services that they meet you at the hospital, they follow you home post-discharge, they encourage you to get connected to any social services that you're eligible for, they try and make sure you're taking your medications, you're getting in to see your primary care provider within a week after you've been discharged from the hospital, you're getting in to hopefully see any specialist care you need. And you see exactly what was described in some of those articles, this dramatic decline. So you can see in, the 2 quarters prior to when they get admitted to the program and the index admission, the number of hospital admissions is, it's always high. I mean, a 20 to 30% hospital admission rate per quarter is enormously high. And it's, soaring right before admission. You actually had to have it admissions in the previous 6 months to be eligible for the program. And then quite impressively, in the 2 quarters, the 6 months after admission, you see this dramatic decline in hospital admissions. That looks like potentially great success until we look at what's happening in the control group, which were the same people, but randomly assigned to status quo care. You see the exact same decline in readmission rates in the control group. And this is just, a classic phenomenon of mean reversion. I think another example, this comes up if there've been a bunch of accidents at an intersection. Sometimes the city will go and put in a traffic light or a stop sign at that intersection, and you will often see that then accidents decline. And there's the question of, is it because the stop sign or the traffic light is reducing accidents, or because they went in when accidents were abnormally high, and even if they hadn't done anything, accidents would have gone down. And this is, I think, a very general phenomenon when you think about healthcare interventions, because just in the same way that we spend money on people when they're very sick and therefore have a high death probability, as in the previous example, we tend to go in with medical interventions when people have had some event that is reducing their health and pushing up their health spending beyond what is typical. And so there would be a natural tendency without any intervention to have some mean reversion. That doesn't mean that policies can't be effective, but it means that to actually investigate whether these policies are effective, it's incredibly important to make sure you're not picking up mean reversion. And the simplest, most rigorous way of doing that is to run a randomized trial, because then any mean reverting tendencies, as you will see here, we'll also see on the control group. So as I said, we randomly assigned 800 patients with medically and socially complex conditions to the Camden Coalition's Care Transition Program, or to usual care. We found no impact on rates of readmission in the 6 months afterwards. In the treatment or intervention group, that was 62.3%. In the control group, it was 61.7%. You could see that in the graphs I just showed you. The key point I want to make here is more of a methodological point, which is that if you had just looked at the intervention group, in that time series back here, you would have concluded incorrectly that the intervention groups, the intervention was causing readmission rates to decline by a whopping 38 percentage points in the 6 months after the intervention. Separately, I will say the Camden Coalition continues to be an exemplary organization and thought partner. You could imagine organizations, even if they had the courage to run a randomized control trial, to try to run from the results and, when they, are not what they were hoping for. But this is an organization that is really dedicated to improving patient lives, not to just patting themselves on the back. And they have really dug in to better understand this result. We've done some work with them on that, and I'm happy to talk about it more in the Q&A if people want, and to refine their program as a result, as Jeff Brenner said in the New York Times about this when this result came out, and I think it's a really just wonderful attitude that I wish we all could have. He said, if there's a promising chemotherapy for treating cancer and you run a randomized trial and it turns out not to be effective, you don't just throw up your hands and give up and say, guess we're not curing cancer. You dig in, you try to learn what you can, as we have subsequently done, of why this program might not be having an effect. You learn from that and you try something else. So this, culture of test and learn, I think is alive and well in the Camden Coalition and will ultimately, I'm sure, benefit us all. Okay, so just to move on, in the interest of time, to the third example, this idea that we spend a lot without getting better health, therefore we could cut spending in high spending parts of the country and save, an enormous amount of money as a fraction of the federal budget or GDP without harming patient health. I want to talk about this next. So this is a typical map from the Dartmouth Atlas, which shows this well-documented phenomenon that there's very large variation across the United States in healthcare spending per capita. These are all elderly individuals on Medicare, so they're 65 plus, they have the same insurance, and these spending are adjusted for differences in age, sex, and race. And you can see that in high spending parts of the country like Miami, spending per capita is twice as high as in lower spending parts of the country like Minneapolis. There's also, though, very large geographic variation in rates of mortality among the elderly, again, adjusted for age, race, and sex. You can see that the southeastern United States has very, very high mortality, whereas, say, the northwestern United States has much lower mortality. I'm not good at looking at two maps and figuring out the correlation. So here is a scatter plot in which we show on the x-axis Medicare spending per enrollee across these different parts of the country, and on the y-axis, 1-year mortality per enrollee, again, age, race, and sex adjusted, and there's no relationship, right? Places that are spending more per capita are not experiencing better health outcomes. And while I'm showing you mortality here, researchers have shown this for a lot of different measures of health. And so, as I said, this fact that healthcare spending varies widely across the United States, but areas with higher use don't have better health outcomes is true. It's attracted a lot of attention. In some sense, it's kind of been seen as a microcosm for what may be wrong with the US system writ large, because it's also true that the United States, as I said, spends, twice as much as a fraction of the economy on healthcare as most other, but is not achieving better health outcomes. Within the United States, this result was incredibly influential in the design of the 2010 Affordable Care Act, because it suggested that, that act, which was expanding health insurance coverage, and that was going to cost money, it suggested that there were substantial healthcare savings to be had if you could get high spending areas like Miami to practice medicine more like Minneapolis. You could have large cuts in Medicare spending. The conclusion was without harming patient health outcome. And as I said, this was very influential. Here's a quote from the 2009 economic report of the president, the year before the Affordable Care Act was passed, saying that these types of gradients that I was showing you, these large differences in spending across area with no corresponding differences in health, suggests that you could cut as much of 30% of Medicare spending without harming patient. And here the fallacy is, that important old chestnut that correlation is not causation. And I can't resist sharing one of my favorite cartoons about that, in which, I used to think correlation implied causation. Then I took a statistics class. Now I don't. Their friend says, sounds like the class helped. Well, maybe, right? Correlation is not causation. Let me show you how we tried to get at this in the case of healthcare spending. Our basic question is, are differences in healthcare use across these areas driven by differences in supply, differences in the way physicians practice medicine in Miami versus Minneapolis, or, in the amount of physical capacity that hospitals have, or the amount of technology they have? That's sort of the narrative by which, well, look, they're just doing more stuff and not getting better outcomes, so maybe we can cut it without harming patients. Or are these differences in healthcare use driven by differences in demand? So differences even among patients of the same age, race, and sex in their health and therefore their need for healthcare, or perhaps in their preference for healthcare, whether they, want to have heroic measures and major interventions or not. Now, obviously, many people were aware of this. We were not the first, and they tried their best to look at this by controlling for everything about these patients they could observe, including, measures of their health, etc. And that was where this general conclusion came from, that even if you control not just for age, race, and sex, but all patients' comorbidities and everything we know about them, you still have these really, really large differences in healthcare spending across areas that aren't correlated with better outcomes. The problem is, you worry, can you really control for all aspects of health? Certainly, how do you control for preferences? Narrative that it's all waste assumes that it's the supply side, and our idea for how to get at this is to look at what happens when people move across areas. So the thought experiment I want you to have in mind is an elderly patient who moves from high spending Miami to low spending Minneapolis, or alternatively from low spending Minneapolis to high spending Miami. If, as the narrative of waste assumes, the differences in spending between those areas is all about supply side factors. There are more doctors in Miami, they practice more intensively, they have access to more hospital beds and more machines. Then when a patient moves from Minneapolis to Miami, their healthcare spending should change to look more like the typical person in Miami. If, on the other hand, the reason healthcare spending is low in Minneapolis is because patients in Minneapolis just are much healthier in ways that we haven't been able to control for than patients in Miami, or those patients in Minneapolis just they're stoic, they don't like to get medical care, and they don't use as much care, then when that patient moves to Miami, their health and preferences don't instantaneously change, and we should see them continuing to use healthcare like they were doing back in Minneapolis. So to see that, to see like a graphical depiction of this, what I've shown you here is on the x-axis, we have the difference in average healthcare utilization between the destination that the individual moved to and the origin from where they came. So, a patient on the far right here might be moving from low spending Minneapolis to high spending Miami, and a patient on the far left whose utilization is lower in the destination than in the origin might be moving from high spending Miami, from moving from high spending Miami to low spending Minneapolis. And what I've plotted on the y-axis here is the change in utilization from before the move to after the move. So all of these people are moving. If you think people move because they're in worse health, that's which you kind of can see because they're all above the comparison to a set of non-movers who are matched on observables. That's not what we're picking up. But what we're picking up is that when you move from a low spending place to a high spending place, your utilization is going up and vice versa. And so to see this in an event study, this is stylized. No data actually looks this good. But what you see is we're looking at utilization, the change in utilization from before versus after a move, or relative to the year of move, based on that size of the move, the difference in utilization between the destination and the origin. And to the extent that your utilization moves when you change, that's getting at the role of place, and any changing is the role of patient. So if this line were totally flat, that would say that everything was about the patient, that my utilization doesn't change between Miami and Minneapolis because it's all about my demand for healthcare. And if this was perfectly vertical at 1, it would say it was all about the place. And where the slope is, I drew it because this was my graph at that I made up at 50%, because that's about what we found in the data, which never looks as pretty as the stylized graph, but as you can see, shows a quite compelling, increase in utilization when people move from lower to higher spending places, or correspondingly a decrease when they move from higher to lower spending places. And so what we're finding is that about half of geographic variation is due to the patients and the other half is due to the place. So relative to this narrative that it's all waste and therefore we can cut healthcare spending without harming patients, it being the difference in spending is all waste, and we can cut that, Miami down to Minneapolis without harming patients in Minneapolis. This says that, maybe about half of it is potentially waste. You then have to do more to see if it is waste or they're just in some different equilibrium of spending. But, half of it reflects patient preferences, either in the form of they're in worse health or they want more medical care. And that, I think, gives you some pause in thinking about those headline numbers. All right, turning in the last 10 minutes or so to facts which are more about insurance than about healthcare spending. The first is about the role of the emergency room for uninsured patients. There's a common claim that the uninsured use the ER more than other types of care, and the answer is that they do. If you look at uninsured adults and the probability they use the emergency room in a year, that's 12%. It's not dramatically higher than for the privately insured. It's actually lower than for the publicly insured. But what you see is that the uninsured are using other types of care like doctor visits or hospital admissions much less than the privately insured or the publicly insured. So another way of saying this is the uninsured are getting a much larger share of their care from the emergency room than from doctors' offices or hospitals than the insured individuals. And so that fact is true. The conclusion that has been widely drawn from that, though, is that expanding health insurance is a great way to not only hopefully improve people's lives, but to actually save money, because expanding health insurance will get individuals, uninsured individuals, out of the expensive emergency room and into cheaper and arguably more effective primary care. So this also figured very prominently in many of the discussions around the Affordable Care Act with the then Secretary of Health and Human Services, Kathleen Sebelius, saying that lack of insurance has forced too many uninsured Americans to depend on the emergency room for the care they need. Republican Governor of Michigan, Rick Snyder, in urging that his state expand Medicaid under the Affordable Care Act, argued that not only are we saving money, but we're going to improve health. And the fallacy is, once again, that important point that correlation is not causation. And the way we looked at the causal effect of health insurance on emergency use was via the Oregon Health Insurance Experiment, which was that the state of Oregon in 2008, because it didn't have enough money to cover every low-income uninsured individual with Medicaid if they were not already categorically eligible. So they had a program to cover low-income uninsured individuals who weren't, disabled, on cash welfare, weren't a child, were between 19 and 64. In essence, the population that then got their coverage expanded under the Affordable Care Act. They decided, with no input from researchers, actually, in talking with stakeholders and deciding what was the most fair thing to do, was to run a lottery for spots for Medicaid. They ran a big public relations campaign, advertising for uninsured individuals who were interested to sign up. And then they literally randomly drew names to pick who would get Medicaid coverage and who would not. And so we were fortunate enough to be able to partner with officials in Oregon to track lottery participants, both those who won and those who didn't those who won and didn't win the lottery, to see what happened on a variety of dimensions. And in terms of emergency room use, you see that in the control group, the uninsured individuals who did not win the lottery and for the most part remained uninsured, you see, for example, on average, over an 18-month period after the lottery, they're having a little over one emergency room visit a year. On average, about 33% of them are having an emergency room visit. But if you look at what happens to the winners who win the lottery and get on Medicaid, their emergency room use is going up by a staggering almost 40% in terms of number of visits. Now, one of the responses we got to this result is, well, maybe that's because they can't get in to see a primary care physician, and therefore, even though Medicaid should be getting people out of the emergency room and into primary care, if physicians aren't willing to accept Medicaid, that's not going to happen. In point of fact, though, we saw also that there were increases in use of primary and preventive care, prescriptions, outpatient visits, also flu shots, mammograms, etc. So it looks like what is going on is actually that the emergency room, while it's required by law to treat everyone regardless of their resources, is allowed to bill people. And so although Medicaid, it's true, makes primary care free for individuals and makes it therefore easier for them to afford it, it also makes the emergency room free for individuals and therefore makes it able for them to afford it as well too. So in other words, insurance increases healthcare use, but it does it across the board, primary care, prescription drugs, hospital use, but also emergency room use. And whatever, you may still have many good reasons to think that we want to expand Medicaid coverage to cover the uninsured, but it would be a fallacy to argue that that will get people out of the emergency room or save money. There's no free lunch here. We have to consider the trade-offs of where we want to spend taxpayer dollars. So the final one, let me just talk about before wrapping up, is on the notion of medical bankruptcies and the fact that over half of people who go bankrupt have had large medical bills in the past few years. And that was well documented by a number of researchers, including when she was an academic by Senator Elizabeth Warren. And the conclusion that these researchers tended to draw is that expanding health insurance would get rid of most bankruptcies. So various laws were proposed, to sort of reduce the risk of medical bankruptcy. One of the arguments that President Obama made for the Affordable Care Act is that the high cost of health care for those who are uninsured causes a bankruptcy in America every 30 seconds. Elizabeth Warren co-sponsored a bill to try to, called the 2014 Medical Bankruptcy Fairness Act, on this notion that medical bills are the leading cause of personal bankruptcy. The fallacy here is something known as outcome selection, and I think it's best explained by way of an example. Suppose you wanted to ask, what makes someone a successful technology entrepreneur? You're thinking you'd like your child to go in this direction and you're trying to figure out, what's the best path for her to end up as a successful technology entrepreneur. Well, you might notice that many successful tech giants in the current day, actually dropped out of college. Bill Gates, Steve Jobs, Mark Zuckerberg. When you start to think about it that way, maybe dropping out of Harvard is a particularly lucrative strategy. And I say this tongue in cheek, but it's pointing out a real fallacy that just looking at where people ended up and not at the risk set from which they were drawn can lead to these very fallacious inferences. It is true that there are a bunch of technology entrepreneurs who dropped out of college, including out of Harvard, but that doesn't mean, but there are also a lot of people who dropped out of college who aren't doing as well. And that doesn't mean that on average, dropping out of college is a path to success. And so the way we tried to look at this was take the ex ante perspective rather than looking at people who had gone bankrupt and ask if retrospectively then did they have medical expenses. We looked at people who went to the hospital for a non-pregnancy related hospitalization and then looked after the fact prospectively at the probability they went bankrupt. And among the uninsured, you do see it is correct that if you go to the hospital, that increases your rate of bankruptcy. And that doesn't happen nearly as much among the insured. But if you look at the magnitude of that effect, it's small. The effect of hospital admissions can account for only about 4% of personal bankruptcies. And some large share, like 2/3 of the high spending on medical care is on patients who have had a hospital admission in the last year. So yes, medical care does lead to bankruptcy, but it's nowhere near the half of all bankruptcies that had been being claimed based on this retrospective approach. But I want to emphasize, it's not just that, we got that fact wrong, but in doing it, we missed something else, which is that hospital admissions do cause great financial harm. That same research design where we followed people after they'd had a hospital admission, we find that even among insured adults, so they have their medical expenses almost entirely covered, the hospital admissions causes a 20% decline in earnings and employment. Now, perhaps that's not so surprising because hospital admissions, are correlated with poor health, and therefore, poor health may cause people to drop out of the labor force. But it suggests that one of the great economic harms associated with poor health is not bankruptcies per se, but actually the much more common inability to continue to work and earn the same amount, which suggests that maybe instead of focusing on bankruptcy reform, we should actually be focusing on, reform of things like disability insurance, sick pay, etc., where in other countries like Denmark, which have very, very similar rates of declines in earnings and employment after a hospital admission, they have much, much less declines in income because that lost earnings is being replaced by government mandated paid sick leave and disability insurance. All right, so let me just wrap up because I'd love to also have time to hear your thoughts and questions. So, on the one hand, I think a key message from this talk is that there aren't easy fixes. Expanding health insurance is not a free lunch. It's going to cost money. That doesn't mean it's not worth doing, but let's understand what it is doing. Nor is it a solution to bankruptcy. Likewise, if you're trying to cut healthcare spending without harming patients, it's not obvious how to do it. We can't just push Miami down to Minneapolis levels and be confident that there will be no effect on patients. We can't just cut off spending at the end of life because we're not exactly sure, who actually is at the end of life at the time that we're treating them. And while a lot more work needs to be done on designing good coordination of care programs for these super utilizers, it's not clear we've cracked that nut yet either. So I want to end on a somewhat more optimistic note by drawing inspiration, as I often do, from my colleague Esther Duflo, who Abhijit Banerjee and Michael Kramer shared the 2019 Nobel Prize in Economics for their pioneering approach for using randomized evaluations to determine how best to alleviate global poverty. And Esther gave a lecture to the American Economics Association in 2017 with a wonderful title. You might wonder why I find inspiration in the analogy of us to a plumber, the economist as a plumber, but bear with me. I really think it does provide inspiration. She says the economist as plumber installs the machine in the real world, carefully watches what happens, and then tinkers as needed. So rather than, grand theories of, we can just cut spending at the end of life, or, we need to, we need to just make Miami be like Minneapolis. And believe me, I remain optimistic. Someone comes up with a grand theory and it turns out to be correct. That would be wonderful. But until that blessed day, we can at least tinker like plumbers. And just as one example of this was a paper, I think it just got published last year because publications in economics take a while, but that I did with my co-authors, Laurent Einev and Neil Mahoney at Stanford, in which we did a rather in-depth study of a rather esoteric and somewhat idiosyncratic institution called long-term care hospitals in the United States. And we concluded that it costs the government a lot more to send a patient, if a patient goes to a long-term care hospital, than to a skilled nursing facility, but the health outcomes for the patients and the well-being outcomes for the patients as measured on, days till they get home or something, are basically the same. And so we say that if Medicare can, would instead reimburse long-term care hospitals like skilled nursing facilities, because they're effectively performing the same function, that could save about $5 billion a year with no harm to patients. Now, in the grand scheme of healthcare spending, $5 billion per year is unfortunately not very much, but $5 billion here, $5 billion there, if we all keep plumbing, hopefully soon we'll be getting into real money. So thank you very much. I'm going to stop sharing and happy to open it up for questions.
Thank you, Amy. That was a fantastic presentation. I have so many screenshots and so many ideas for, personally, I'm going to incorporate this into the course I teach my MBAs about decision-making and biases. And these are just fantastic insights. We have tons of questions, so let's jump right in. One that I wanted to ask, and we're going to like go back in time because it's been a little while since you were talking about the Camden Coalition, but we had a question coming in that I think is a really great one. You mentioned what an excellent partner they've been, and that they really wanted to try to dig into the data and learn what might be working, and you know, not just that their program was a failure, but try to figure out were there any components of it that could be saved, or components that were effective. And so one question we have from the audience is just if there are any learnings since on elements of that program that might not have been completely null or that seem more promising than others.
Yeah, that's a great question. I can't say enough amazing things about the Camden Coalition as a partner. My only complaint with them is that there aren't more organizations like them, but I hope that other organizations will be inspired by them to do this incredibly difficult work of, you know, turning the spotlight on yourself and really subjecting what you're doing to rigorous testing, because as I said, their goal, and I think most people's goal in this field, is not to pat themselves on the back, but to really improve patient lives. And so, yes, we did dig in with them. And actually the sort of first order question, you know, first we talked to them. Obviously, they had much more insight than we did as to what might be going on. And one of the first, you know, questions that came up in some big bucket level is, was this a failure of implementation or a failure of the theory of change? So the Camden Coalition's theory of change is if you can take these very vulnerable, very sick patients who are cycling in and out of the hospital and connect them with available resources, make sure they get in to see their primary care physician, make sure they're taking their prescription medication, connect them to, you know, food stamps, cash welfare, other things that they're eligible for, can we break that cycle? So was that theory of change wrong? Or was it just that, you know, they didn't implement the program successfully? And so we did, you know, it turns out, for mostly uninteresting reasons, that turns out to be a much harder question to answer than what happens to hospital readmissions, because then you need like a lot more granular data on primary care use, prescription drug use, et cetera. The vast majority of these patients are on Medicaid. So after a lot of work and a great partnership with researchers at Rutgers, we were able to link them to the Medicaid data and answer this question. And the answer was that by most metrics, they were actually, implementation, while not perfect, was of the order of magnitude that it has been successful in other programs that have found positive effects of these post-discharge programs. So we found that, for example, the program increased the probability of having a physician visit in the 2 weeks after your hospital discharge by 15 percentage points. This was driven primarily by an increase in primary care use, and those effects persisted through the year after the discharge. And these are comparable to the sort of increases in outpatient care use that have been found in other programs, these post-discharge programs that have been deemed successful. So our interpretation from that was, of course, you know, the base, I think, was maybe 20%. So going from 20 to 35% is not getting everyone in, but this program was at least getting success rates along the lines of other programs. And that just wasn't enough to reduce hospital readmissions. Now, what we do from here, that's where we turn to our partners in the field for guidance. And I think there's a wide variety of reasons. The Camden Coalition is itself experimenting with additional services such as housing. They're saying there are a lot of barriers among people who are homeless, you know, and they're trying a bunch of additional services to add on. Dr. Brenner, who is now leading another organization, he's no longer with the coalition, his interpretation, and I think these are both valid interpretations and we need more evidence, is he said, like, look, my theory of change, I'm speaking as Dr. Brenner here, when I founded the Camden Coalition, was that the reason these patients were cycling in and out of the hospital was obviously there's some underlying medical issue, but there's fundamentally a failure of social support, and there's great social support services out there. What we need to do is connect them to them. And what he says he's taken away from the results is, and I think this is his quote, we were connecting them to nowhere. We were coordinating to nowhere. And that actually for these very, very sick, very economically vulnerable patients, you need not just to connect them to existing resources, but to build what's sometimes called an ambulatory ICU, a very intensive set of wraparound services specifically designed for those patients. I believe he's working now to do that. I spoke with him, I think, most recently about a year ago, and he said, you know, we're 4 or 5 years away from being ready for an RCT, but we'll be sure to call you. And it's that kind of energy, passion, and determination laced with a real desire to rigorously test and learn that is just so amazing in the Camden Coalition and in Dr. Brenner.
So Amy, this
Thank
is a question turned into a comment, and then I'll give you the question. So first of all, +1 to the Camden Coalition for being willing to do this RCT. We all recognize how important that is. I think it is important to note, as you did and as Jeff Brenner did, this is an N of 1, and you're evaluating one particular model implemented one particular way. So it doesn't mean that hotspotting can't work. It's like you said with the drug trial, crack one didn't work,
100%.
let's consider other alternatives. So that's what we all need to keep in mind.
100%. And how do we learn from what didn't seem to work to then form new hypotheses and test them out? There's another series of hypotheses about, you know, maybe reaching patients before they become super utilizers would be more effective. Now, the problem there is there are many more patients that are at risk of becoming super utilizers that are, but that could work. It could be a lot less expensive. Again, we need people who have creative ideas in this space and then are willing to implement them and test them. But I 100% agree. The most important thing is we haven't learned that there's nothing to do to help sick, vulnerable individuals. We've learned that we need to keep trying.
So the question I was going to ask is, what implications do your compelling findings have across the health policy development process? Thinking about agenda setting, formulating, implementing, evaluating, what type and level of policymaker, what steps in the process need debiasing? How might that best work? What advice would you give?
I'm sorry, you cut out for 1 second. You're asking about what parts of the healthcare policy process should we, what
Yeah.
advice do I have?
How could it be informed so that these kinds of fallacies aren't what drive the narrative in the future?
So that's a really good question to which I don't have a great answer. I think part of it, you know, Katy mentioned the course she's teaching her MBAs. I think, you know, all the work that we do as educators to try to communicate this, I think we can and should do better jobs of also communicating to a broader public. If you think of, you know, like the book Katy wrote, like this is part of our job is if we have, you know, important insights to try to get them out there. I took inspiration for my talk from a wonderful book actually by a math professor, Jordan Ellenberg, called How Not to Be Wrong, which consists of many of these fallacies outside of the healthcare space. So how do we create a more informed, logically thinking public? I think that's the work primarily of educators, both inside and outside the classroom. And then, you know, the responsibility of the media to not buy into the easy fallacy and to ask the hard, and sorry, the media and the policymakers. But, you know, it's always tempting to say, look, we have a new silver bullet. And so it's the responsibility of all of us to try to be measured and thoughtful. I don't have a better answer than that.
That's a very good answer. I'm going to ask you another hard question, but you know, we haven't talked about AI once in 53 minutes, and it's the end of 2025. So it's time for an AI question. One of our audience members wanted to know if you have ideas about how AI can be used to experiment with and tweak healthcare to obtain better outcomes based on the work you've already done. Maybe there's projects in progress you could tell us about. Everybody's got AI on the brains.
Yes, in fact, you're not talking to me, you're talking to my avatar. So I don't have good thoughts on this, but I am reassured and relieved to the fact that many bright people, including several of my colleagues, are working on this. My colleagues Sendhil Mullainathan and Ashish Rambanjachan are doing a lot of interesting work on this. My colleagues Nikhil Agarwal and Tobias Saltz have what I think is one of the best recent papers on this, looking at the use of AI in the common area where this has been done a lot for reading scans instead of radiologists. And their key insight there is that these AI algorithms don't operate in a vacuum. At the end of the day, the AI is always going to be an input into a physician decision making. And so a key question is not just, as a lot of papers have shown, that in many situations, the AI is better than the physician at not having false positives or false negatives, but how is a physician who has looked at a scan herself going to incorporate the AI into their own decision making? And there they find, right up the alley of the kinds of things that you work on. There's a lot of behavioral biases in how physicians update on the basis of the AI report, that they're not perfectly rational Bayesian updaters. And so I do think one of the key things to think about is not just the first level work that's been important work that's been done on which is better, but how these interact in a non-AI, but what passed for high tech 10 years ago situation. I had an opportunity to look at this when we were looking at clinical decision support, to the alert that pops up to tell the doctor that maybe they shouldn't order that high cost CT scan for when someone walks in with a headache. And we ran a randomized control trial that found, spoiler alert, it did absolutely nothing to physician behavior. But part of it is we were constrained to introduce that alert where it was currently in the physician work stream. And you can imagine that if you've gone to the trouble to examine the patient and form and do your differential diagnosis and make a decision, you're less likely to update than when the machine, when I want to give my student a B and then the dean asks me about it, I've already decided on that B, right? But if the dean or the clinical decision support comes in at a different point in the process, maybe it would have a different effect. I don't know. We didn't get to run that RCT, but as drawing on Kevin's point that the answer isn't it works, it doesn't work, let's give up or celebrate. I think what we have to do is, in both these examples, move on to think about not just how these tools perform in a vacuum, but how they interact with the real-time decision making that real people, or at least physicians, are making.
I love that, Amy. I know I'm going to
So
pass the
Amy,
baton to Kevin for a last question. I just want to make a little quick shout out to anyone tuning in who's at Penn. Sendhil Mullainathan is giving a talk on AI and healthcare on Monday at noon in Steinberg Dietrich Hall 1206. So please join us.
Yeah,
for that.
please say we just had your colleague on and she had nothing to say about what AI could do for healthcare. So we have you here and I want to know what he's going to say. So that's great.
We'll say Amy said we should ask you.
Yeah, exactly.
So Amy, there are a lot of really good questions that we're not going to be able to get to. I'm going to ask you one more question and just ask if you can give us a 1-minute response. It is not an easy question, but can you describe a healthcare system somewhere in the world that you think works really well in terms of achieving good population health outcomes and better controlled costs?
Yes, I can. I should have come prepared and I will advertise my book. The short answer is any high income country outside the US to first order gets it right compared to the US, by which I mean they have universal coverage with the ability to supplement if for people who want more than the very basic universal coverage, and they have a healthcare budget, which means a binding budget constraint. Unlike in the US, where the Medicare budget doesn't mean how much you can spend, but how much you have spent or how much you will spend, they impose binding healthcare budgets, and then they have a universal basic coverage, and then they allow people to supplement if they want. And what we learned, my co-author and I, after a lot of hard work and thought, was pretty much where I think a lot of lay people have ended up. And maybe this is a good place to end, that not everything that's out there in the popular wisdom is a fallacy. And in fact, it turns out that it's actually not that hard. It's not rocket science. It's barely economics, but it is possible to develop a much better health insurance system.
Great. Well, that does seem like a good place to end. And Amy's book sounds like a must read that we should all try to find. So I want
It's
to
in the
thank
chat. It's in the chat.
Dr. Finkelstein for joining us today and for this really interesting set of remarks. I want to draw your attention to our upcoming other speakers. We have a fabulous lineup coming up, so please do tune in when the time comes. And the link to register is here below. Thank you to everyone for joining us today. Thank you, Katie, and most of all, thank you, Amy.
Thank you so much to all of you for this great conversation, and I look forward to many more. Thank you.